The next session is stress, distress, de-stress. How ICD-11 changes your concept and practice of stress-related psychiatry by our speaker, Dr. Rajesh Sagar. For this session, I would like to invite the chairpersons, Dr. Subodh BN, who is currently Additional Professor in Department of Psychiatry, PGIMER. His areas of interest are addiction psychiatry, clinical psychiatry, and community psychiatry. He has around 58 publications to his credit, and he has won the Early Career Psychiatrist Fellowship Award. Our next chairperson is Dr. Lalit Kumar. He is currently Assistant Professor of Psychology in PGIMER Chandigarh. His areas of interest are clinical psychology, psychotherapy and counseling, clinical neuropsychology, psychiatry, and mental health. He has around 14 publications and 6 book chapters to his credit, and he has won the Best Paper Award at the Indian Association of Clinical Psychologists in Secunderabad. I invite the chairpersons to introduce the speaker and carry on with the session.
Good afternoon, everybody. Today's speaker needs no introduction. Everyone in India knows Professor Rajesh Sagar, and his areas of specialization are child and adolescent psychiatry, community psychiatry, consultation license psychiatry, and adult clinical psychiatry. He has more than 300 publications in peer-reviewed journals and has 66 chapters and 6 books written by or edited by him. He has several awards. A few among them are the DJ Cohen Fellowship of International Association of Child and Adolescent Psychiatry and Allied Professionals at the 17th World Congress held in Melbourne, Australia in 2006. He is member of the National Academy of Medical Sciences, appointed as Honorary Consultant to Public Health Foundation of India in 2009, awarded the Fellowship of International Medical Sciences Academy 2009. With this brief introduction, I invite Professor Rajesh Sagar for his talk.
Good afternoon, everyone. I hope you can hear me. Dr. Subodh, thank you, chairpersons. You can hear? Okay, yes. Wonderful. I will just share my screen. Yeah. Fine, and you can see my screen also, isn't it?
Yes, sir. We can see your screen.
Great. So my thanks to the organizers, Professor Basu and the whole team to have this particular topic and to invite me, and this becomes a very, very important discussion on ICD-11 and the whole issue that how we are going to know the newer concepts and how it's going to change our practice in that way. So it becomes a very important discussion, and I must congratulate the whole department, Professor Basu and everyone to think about this very important topic, because when we started resident ICD-9, then we worked ICD-10, now we have ICD-11. And this becomes a very important discussion, especially for all of us and more so for our younger faculty. This topic is basically on stress-related psychiatric disorder. And if you can see, because the whole discussion which has been there and in the today's context becomes very important. So these are the learning objectives. So what are these new classification of stress-related disorders in ICD-11, and how we are going to differentiate between normal variation of stress to other pathology, and to understand the differences of in ICD-11 condition as compared to ICD-10 and DSM-5. I will briefly touch upon that, how to make accurate diagnosis based on ICD-11, and what will be the implications of it. I think this will be the brief outline of my presentation. Now, it is very important that we need to put this context very clear for this presentation. And there would not have been a better time to discuss than current time, when we are talking about trauma, stress, COVID-19 and so on. So I think in that context, this topic becomes very important, very, very important. And especially in the context of, talking about PTSD and other stress-related condition in view of the pandemic. So basically, not only to the people who are COVID positive, who have a COVID illness, we all know the whole gamut of psychiatric illnesses during COVID, or even post-COVID, has become very important in current time. But it's not only those who are suffering from COVID, but also these psychiatric conditions and stress-related conditions are important for family members, healthcare worker, and those who have witnessed sufferings and deaths. We know that the deaths which took place in the second wave, especially. So it really, it is important to discuss about stress-related conditions. And also the individuals who have learned about deaths or risk of death of a family member or a friend due to this virus, and individuals who have experienced extreme exposure to these aversive details. So what is important is these stressors have emotion and emotion. Such as social isolation, unemployment, economic losses, working from home and caring for children, and so on. So whole, not only just COVID-19, but associated condition related to COVID-19 now also has brought the stress-related condition. Among the healthcare workers, we all know the strains which have been there with regard to PPE, with regard to fear of virus exposure, burnout. We have been talking about it. And some of the heroic efforts which have been there. So in that context, this chapter becomes very, very important. So I just wanted to put this in the context very clear and what the current scenario is. Now, we all know about stress, I think, and I would say for psychiatric, it's a bread and butter, and we do keep hearing about stress in psychiatry, and we do discuss commonly about psychiatry. So what stress is? Simple definition is basically there are a number of definitions. It's any type of change, or one can say stimulus, which brings the physical, emotional, or psychological state. Or in other words, it is a normal reaction to the abnormal stimulus. And or in other words, it's the imbalance of resource and the demands which are being placed. So different definitions are there. And so that is what is stress, and we have been discussing about it. And stress responses, again, how a body adjusts to the new situation. So, so one can see that the current pandemic, COVID-19, that how we are adjusting to it, it's also kind of a stress, and that's the feature of a stress. Everyone experiences stress to some degree. I think that's a very, very important point, that some degree the stress is experienced by all of us. We all know only a dead person will not have a stress. That's what we always say. And the way one responds to a stress, that makes a big difference to overall well-being. I think that becomes a very important point. And in the sense that if you see the definition of mental health, as per WHO, if you see one of the four tenets of is that how we deal with the stress of day-to-day life becomes a part of mental health. And the acknowledgement of stress as external source is important aspect of mental disorder. And of course, it's relatively newer because we all know that one of the basic feature of psychiatric classification is the atheoretical, and we don't attach any kind of a theory to it or causative agent to it. But in sense, stress becomes important in that way. Almost all psychiatric disorder to some extent are shaped by the stress. And of course, we all know that, for example, psychosis tend to have much milder symptoms or even remain in the remission phase at a low level of external stress. Okay, so just to carry on with this, stress, what is important is identifiable causative factor is not necessary for the purpose of diagnosis. As we were talking, it's atheoretical. We don't attach to anything except for two conditions that we all know, like, where the substances or the organic causes. Like in organic causes, we always look for any medical or neurological condition for the onset of psychiatric symptomatology. So these are two important exceptions where the causative factors need to be there. We can add the stress-related condition also to this exception. Despite the difficulty to define and the measuring the stress, of course, we do have a scale where how we can identify, how we can measure stress, but still there is a lot of difficulty in that. And associated events are perceived, considered as a traumatic, can be identified in most situations. We all know. But sometimes stress triggers in psychiatric disorder may be subtle and the cumulative also. And we all know some of the measures of the stress, there is a cumulative effect which is there. So the point is that we all know that it's difficult to measure stress, but to really document a stress, we need to look at some of the stressful triggers, which again may be subtle and cumulative. Now, here it is very important. If you see the parallel chapter in DSM-5, the word trauma is used, trauma and stressor related conditions. That trauma is there, but in ICD-11, the word trauma is not there. If you look at it, it's a stress related condition. Now, the reason given by the working group is that, to talk about stress, and to reduce the tendency to brand someone or to label someone seeking professional help as psychologically traumatized. That's a stand taken by ICD-11, where the word trauma is not there in the major chapter or major. It's just a stress-related condition. The trauma word is not, though it is there in the DSM-5. Now, what was there before ICD-11? I think it is very important to know about it and what has been the genesis for the whole this stress-related condition. We would say that as a separate chapter, it's a relatively newcomer to psychiatric classification. If you remember ICD-10, what was there? It was stress-related, neurotic, and somatoform disorder as a condition, where it was all clubbed together. But in ICD-11, there is a separate condition, stress-related condition, which we'll talk about that later. And of course, after the documentation of acute stress during Second World War was given by Dr. Henry Wilson in Lancet 1942, and where the whole experiences were given in the sense that acute emotional disturbances to stupor, hysterical paraplegia, but most of these patients were discharged within 24 hours. And ICD-8, we all know it's a transient situational disturbance were documented that included adjustment problem, severe stress condition, and combat neurosis. I think it was in ICD-8. ICD-9, of course, two disorders were mentioned, that is acute stress reaction and adjustment reaction. In ICD-10, we all know, that there was important condition in addition to acute stress reaction and adjustment disorder, post-traumatic stress disorder was added, ICD-10, and F62 was enduring personality change after catastrophic experiences, which could appear following exposure to stress of an extreme nature, that is torture or concentration camp, imprisonment, and so on. ICD and DSM, though the trend is to converge, but of course they do diverge significantly also with regard to stress-related disorder, like disinhibited type of attachment disorder, in both, that is disinhibited attachment disorder (DAD) in ICD-10 versus disinhibited social engagement disorder (DSED) in DSM-5. So there's some diversion is there in that way, but the important thing is that stress-related conditions are placed after anxiety and OCD in DSM as well as in ICD-11 also. Now, just to give you, in fact, if you see the first page itself of chapter 6, mental behavior and neurodevelopmental disorder, I will not go into detail of this, but you can see the exclusion. It's mentioned in the first page itself, the exclusion, acute stress reaction and uncomplicated bereavement. We'll talk about that later, but what I'm trying to highlight here, in the first page itself, the mention of stress reaction is there. And of course, there are 20 chapters, we all know, at the top level blocks, and it's mentioned as disorder specifically associated with stress and which comes after neurodevelopmental disorders, schizophrenia, catatonia, mood, anxiety, and obsessive compulsive disorder. So that way the placement is similar to DSM-5, but so that's how it is there in ICD-11. Now, these are disorders specific to stress. That is the block L1, B6, B4. That's how it's described. And the term which is being used, which all it's so important, directly related to exposure to a stress or traumatic event. Here, the term traumatic event is used, or a series of such events or adverse experience. So that's how it's described. And there is an identifiable stress is a necessary, though not sufficient as a causal factor. I think that's what the expression is used in ICD level. And the disorder would not have occurred. I think that's what the main emphasis on, would not have occurred without experiencing the stressor. So that's how it is expressed. Maybe within the normal range of life experience, we all know, there are two types of stressor which can be there, like, which are the normal range of life experience, like divorce, socioeconomic problems, or bereavement, or extremely threatening or horrifying nature. So two kinds of stress which are described. So of course, this stress-related condition, is applicable to both of these, but with associated functional impairment. So this is something very important, and that's how it differentiates with the normal reaction. In that way, a normal variation of stress-related problem versus a disorder, we all know, where there is a functional impairment. So it's in line with DSM-5 in these things. And of course, there are exclusions with regard to burnout, which we'll talk, and acute stress reaction. So if you see the earlier editions, versions of ICD, acute stress reaction was part of it, ICD-8 onwards, ICD-8, 9, 10. But in this, it's exclusion. And of course, the burnout, which we are talking so much about nowadays after pandemic, but actually it's exclusion in the disorder category. So this is these are the conditions, disorders which are associated with stress. Like just to name them, post-traumatic stress disorder, we all know such an important condition, especially in the current situation. Now, this is something new which has been added, that is a complex post-traumatic stress disorder, which is not there in the DSM-5. DSM-5 only talks about post-traumatic stress disorder. So, but here we have a separate condition about complex post-traumatic stress disorder. Now, this also is a new condition, that is a prolonged grief disorder. This is the new condition which has been added in ICD-11. Adjustment disorder, we all know, which was there earlier also, adjustment disorder, which again has been retained with some minor criteria variation, which we'll talk about that. Reactive attachment disorder and disinhibited social engagement disorder. If you remember, in previous version, these were part of social dysfunction with the onset in childhood. But here in ICD-11, and the same has been there in DSM also, where now it is a part of stress-related conditions. So that's a major change which has taken place, where it was earlier somewhere else, part of the onset in the social dysfunction onset in childhood, but now it's part of the stress-related disorder. And of course, we have these conditions Y and Z, that is other specified disorders specifically associated with stress. And of course, we have unspecified also. So that's how this stress-related psychiatric disorder in DSM in ICD-11, they are like this, which we'll briefly talk about that more in detail. And of course, it all talks about that how they are different, the form of nature, pattern, and duration of the symptom arising in response to a stressor. Now, just to give you a glimpse of it, ICD-11, as we said that that traumatic stress disorder, we have this PTSD and complex PTSD. ICD-10, it was F43, reaction to severe stress and adjustment disorder. It is acute stress reaction, PTSD, and adjustment disorder. Here we have prolonged grief disorder, adjustment disorder, attachment disorder, reactive attachment, disseminated social engagement, and acute stress reaction, which is not a mental disorder. And similarly, it was there. This was as a disorder of social functioning with the onset specific to childhood. Then disorder specifically associated with stress, complex post-traumatic stress disorder, And DSM-5, we only have post-traumatic stress disorder, and of course, adjustment disorder, which again, if a stressor does not qualify for a PTSD or other specified trauma or stress-related disorder. Prolonged grief disorder, which ICD-11, it's that. And what's the equivalent in DSM-5? If you see, the equivalent is, though the brief mention is there in other specified trauma and stressor-related disorder. If you carefully look at the DSM-5 other condition, it's mentioned as a condition for further study as a persistent complex bereavement disorder. So persistent complex bereavement disorder, about 2 lines are there in other DSM-5, and also it's a condition specified for a further study. So that's how the subtle, there is a difference between ICD-11 and DSM-5. Now, we all know, I'm not going to detail so much on post-traumatic stress disorder, but this is how it's described in ICD-11. Following exposure to an extremely threatening or horrifying event or series of events. Now, as I said in the beginning, the normal variation of stress is not part of PTSD. For PTSD, it has to be extremely threatening or horrifying event or series of events. Now, there are 3 things which are important here. 3 to make a diagnosis of PTSD as per ICD-11. That is re-experiencing the traumatic event or event in the present form with the vivid intrusive memory, flashback or nightmares. We all know that this has been the key feature of PTSD. Second, we also know it's so important that's the avoidance of thoughts or memories of the event or events, or avoidance of activities, situation, or people reminiscent of the event. So that's also a key feature. And the third feature, which is there, the persistent perception of a heightened current threat, that is the hypervigilance or enhanced startle reaction. So these are the 3 key features of PTSD as per the ICD-11. And these symptoms should persist for the term which is being used is at least several weeks. There is no specified duration of weeks here, several weeks, and also causing a significant impairment. Inclusions are traumatic neurosis, but exclusion again are acute stress reaction and complex post-traumatic stress disorder, which is a separate category. Now, this is a new condition, and especially our young people who are listening to this, they, if this is a new condition which has been added in the ICD-11, that is a complex post-traumatic stress disorder. Now, what it is? First, it should meet all the criteria of PTSD. We just discussed those 3 major criteria. Now, on top of it, there has to have a event or series of events of extremely threatening or horrifying nature. Most commonly, that's a prolonged or repetitive event. Now, prolonged or repetitive event from which the escape is difficult or impossible. That is torture, slavery, genocide campaigns, prolonged domestic violence, and repeated childhood sexual or physical abuse. So this is what the important thing is, a prolonged or repetitive event in form of this, and which is a feature of a complex post-traumatic stress disorder. On top of it, we need to have these 3 conditions to make a diagnosis of complex PTSD. That is affect dysregulation, which again is an important feature to talk about the complex PTSD. Second is belief about oneself as a diminished, defeated, or worthless, where there is a problem with the self-worth, self-concept, and so on, accompanied by feeling of shame, guilt, or failure related to traumatic event. And the third one is what we call difficulty in sustaining relationship and feeling close to others. So, so what is there? It should fulfill the PTSD criteria, which we all discussed. For complex PTSD, we need to have these 3 criteria to make a diagnosis of complex PTSD. And exclusion is, of course, PTSD, which was there in a previous section. Now, these are 3 important conditions to make an impression of complex PTSD, that is affect dysregulation, interpersonal problems, and negative self-concept. So, now, why this classification? Because there has been some interesting, kind of review which has been there. And just to briefly talk about it, in some majority of studies where the trauma has been exposed in the clinical community or epidemiological sample, and there has been seen a distinct classes has been seen where they report one group as a PTSD and the other group as a complex PTSD. So 2 different groups has emerged out of clinical, community, and epidemiological sample, which is very important. Two distinct trauma population has convincingly demonstrated. And of course, the potential benefit of having two disorders is basically a highly heterogeneous condition. So to improve the patient outcome by personalizing a treatment. So that's what earlier, everything when it was combined, so the becomes so heterogeneous. So by segregating the two, it's a possibility that the outcome may be better with the personalized treatment, and that is what is being commented on. And notably, the diagnosis of PTSD and complex PTSD are made by the reference to symptom. Now, again, this is a very key point here, and not to the type of traumatic event experience. So not to the type of, but only the reference to symptom, as what we discussed, PTSD 3 symptoms, complex PTSD additional 3 symptoms. That's how the impression is made, not to the type of event, where actually the type of event is basically a risk factor, which is the requirement for each disorder. Now, what the evidence is? In fact, there is some interesting literature on this. Women, we all know, are more likely than men to meet a criteria for both PTSD and complex PTSD. So, women both for PTSD and complex PTSD. Cumulative adulthood trauma was associated with PTSD and complex PTSD. So again, cumulative adulthood trauma associated with PTSD and complex PTSD. But cumulative childhood trauma was more strongly associated with complex PTSD than PTSD. So what it means is cumulative childhood trauma is actually associated more with the complex PTSD. Among the traumatic stressors in childhood, sexual and physical abuse by caregiver were identified by as events associated with complex PTSD, whereas sexual assault by non-caregiver, early caregiver, and abduction were associated with the risk factor as a PTSD. So that's some differences has been noted with some of the interesting studies which have been conducted in this. Individual with complex PTSD reported substantially higher psychiatric burden. Now, again, this is very important for mental health professionals. So complex PTSD, there is a higher psychiatric burden and lower level of psychological well-being compared to PTSD and with neither of the diagnosis. And of course, complex PTSD need to be distinguished from the borderline personality disorder, although the comorbidity should also be expected. Now, this is basically the table which is there to differentiate the ICD-10 PTSD, ICD-11 PTSD, ICD-11 complex PTSD. So, which is how the differentiation is there between these three conditions, especially in ICD-11, both PTSD and complex PTSD, and ICD-10 PTSD, basically to look at more nuances. I will not go much detail into this because already time is short. So I will just, so basically again, what I've highlighted in complex PTSD, we need to have these three symptoms, that is affect dysregulation, negative self-concept, and persistent interpersonal disturbances. An impairment again is needed for PTSD and complex PTSD, but it was not a feature in ICD-10 PTSD. So again, that's a very important aspect. In ICD-10 PTSD, functional impairment was not a feature, but here in ICD-11, it is a feature. Minimum duration were not stated in ICD-10, but here the several weeks are being stated, whereas in complex PTSD, it is a persistent. So I hope it's a clear the differentiation by ICD-10 and ICD-11 PTSD and complex PTSD. Now, again, this differentiates this table between borderline personality disorder, PTSD, and complex PTSD. I will not go into detail of this. Already, I have mentioned most of this point. Basically, it is what already we have discussed, but also it talks about some of the brain changes, prefrontal cortex changes, and some of the other biological parameters. Skip this. Now, what the difference is there with DSM-5? I think just to give a glimpse of it, complex PTSD is intended to describe more pervasive and post-traumatic reaction. I think that's what we discussed. There has been evidence for that. It is basically a more pervasive, reaction. And in addition to the core PTSD symptom, and also include the development of persistence, dysregulation, self-concept, and difficulty relationship. Whereas DSM-5 offers only the single category of PTSD, and 3 constituents already we have discussed, which again correspond to the 3 ICD-11 core symptoms. And basically DSM-5 includes additional symptom cluster. There is additional symptom cluster. If you remember, in one of the most complex diagnoses earlier of PTSD in DSM-5, 20 symptoms were there. It was very confusing. So possibly in ICD-11, it has made simplified. And so, of course, this was the additional symptom is there in DSM-5, that is a negative alteration in cognition and mood, which incorporates 2 of the 3 additional requirements of ICD-11 complex PTSD, that is persistent belief about oneself are diminished, defeated or worthless, persistent difficulty in sustaining relationship, and so on. So there are subtle differences which have been there. It is broadly defined ICD-11 in terms of qualifying the traumatic events as what we discussed, horrifying and threatening. That's what the term, which is, it is more narrowly defined in terms of symptomatic response to those events. ICD-11 requires both PTSD and complex PTSD, that trauma be extremely threatening. That's what we discussed. And DSM-5 requires that qualifying traumatic event involve exposure to actual or threatened death, serious injury, or sexual violence. Now, here also you will see a subtle difference than DSM-5. There more details are being provided with regard to traumatic event. So, so it's specified more clearly. It specifies 4 possible modes of exposure. That is directly experiencing the traumatic event, witnessing it in a person as it occurred to others, learning about violent or accidental traumatic event that has occurred to close family member or friend, experience a repeated or extreme exposure to aversive details of traumatic events. So here, more details are being provided in DSM-5. Perhaps there may be a reason to that, maybe because of legal concerns and potential misuse of PTSD diagnosis. And there is, a lot of literature is there because as the insurance cover is there for that. So the reason may be that that's why it has been made much more specific, the criteria for the traumatic event and so on. Now, ICD-11 core symptom, re-experiencing the traumatic event in the present and heightened sense of current threat are more narrowly defined as compared to DSM as such. And ICD-11 includes an intrusive memory, flashback, nightmares, and re-experience the same type of emotions. And the corresponding DSM-5 symptom cluster more broadly defined and also includes psychological distress, whereas ICD-11 core symptoms of perception of heightened threat or restricted to hypervigilance and exaggerated startle response is much more narrowly defined than the corresponding in DSM-5. And of course, these are some of the variation as compared to DSM-5, hypervigilance or exaggerated startle response, and which are being defined in ICD-11. And studies comparing ICD-11 and DSM-5 diagnostic requirement have found somewhat lower PTSD prevalent rate using ICD-11, and that 2 diagnoses do not identify exactly the same group as such. I think and there are some literature available to that they may not identify the same group. Of course, in future more and more such evidence will be coming up. The inclusion in the DSM-5 is there sleep disturbances and problem with the concentration is also there, which also is characteristic of many mood and anxiety disorder, and persistent negative emotional state, diminished interest or participate in significant events. And so, so these are some of the differences which are there in ICD and DSM-5 in this particular category, PTSD. Now, we just, this is the new condition, prolonged grief disorder, and following the death of partner, parent, child, or other person close to bereaved. And there is a persistent and pervasive grief response characterized by longing for the disease or persistent preoccupation, which is there with the disease, accompanied by intense emotional pain, that is sadness, guilt, anger, denial, blame, difficulty in accepting the death, and so on. And where the emotional numbness, and it maybe persist for more than 6 months as such, and exceeds the expected social, cultural, or religious norm. That the phrase has been there, to exceed the expected social, cultural, religious norm, and the disturbance causing a significant impairment in important areas of functioning, and the reactions are within the expected social, cultural, religious norm are viewed as normal bereavement and not assigned a diagnosis. So where it is expected or normal, they are not given this particular diagnosis. Now, because this is a new condition, so just to tell you that the term which were there in 93, that's a complicated grief. We all know, this was used, pathological grief, then traumatic grief in 99, and included the core symptom of separation distress and traumatic distress, along with associated negative emotion. Then 2009, prolonged grief disorder, the criteria were made, along with complicated grief, introduced two different groups and emerged as separate of two separate studies. And in DSM-4, the condition which was there was persistent complex bereavement disorder, which is there now in the condition for the study, as well as in others condition in the stress, in DSM-5. And the symptoms of persistent complex bereavement disorder to be distinct from often comorbid associated conditions such as depression, PTSD, separation anxiety. And there has been enough statistical evidences where the prolonged grief disorder is separate from the other associated conditions. And of course, there has been a subsequent development of prolonged grief disorder and for to ease of case identification, international applicability, therapeutic and intervention implication in that regard. So this is a new condition which is there in the ICD-11. Now, this is the common condition adjustment disorder, just to talk, which was there earlier, has been there for few decades now, starting from earlier version of ICD. It's a maladaptive reaction to a identifiable psychosocial stress or multiple stressor, as such, like divorce, illness, or disability, usually emerges within a month of stressor. And whereas if you see in DSM, of course, in other category, it can be there after 3 months and so on, where there's a preoccupation with stressor or its consequences, including excessive worry, recurrent distressing thoughts, significant impairment in important areas of functioning, not better explained by another mental disorder like depression and so on. Typically resolved within 6 months, unless the stressor persists for longer duration. But if it is more, then of course it can come in the others category. Exclusions are these: separation anxiety disorder of childhood, recurrent depressive disorder, single episode of depressive disorder, prolonged grief disorder, which we discussed, uncomplicated bereavement, which again is not a mental disorder, burnout, and acute stress reaction. So this is about a adjustment disorder. Of course, there are certain differences with DSM. Both ICD-11 and DSM-5 describe adjustment disorder, and the symptom developing response to identifiable stressor that do not meet the additional criteria for other disorder. Adjustment disorder has often been criticized as a poorly defined condition. In fact, some literature is available on this. We all know it's a poorly defined condition because it consists of subthreshold symptoms of stressor. And of course, it is being said it's a post hoc, it's identified stressor. And in response, ICD-11 has added a requirement. Now, this is the key point here, which is not there in DSM-5. That is, a specific symptom be present indicating a maladaptive reaction. If you see there, one of the main emphasis is on the maladaptive reaction to the stressor. That is a preoccupation with the stressor or its consequences, like excessive worry, recurrent distressing thought about stressor, rumination, and so on. And of course, attachment disorder is something, as we said, that has been shifted from other section to this particular section, as we discussed earlier. Earlier, it was under the section of disorder of social functioning with onset specific to childhood, adolescent, F94, but now it is a part of stress-related disorder. And it's basically due to exposure to chronic stress in form of severe social neglect and grossly inadequate caregiving, and to the early developmental period is necessary for the attachment disorder. Both DSM-5 and ICD have taken a cognizance of accumulating evidence which has been that these two disorders have to be described under this particular section of stress-related disorder. Basically, again, two types: inhibited type, that's a reactive attachment disorder, and disinhibited type, which is a disinhibited attachment disorder, disinhibited social engagement disorder, which is there in DSM-5 as well. Now, just a brief criteria, that is grossly abnormal attachment in early childhood, occurring in the context of history of grossly inadequate childcare, that is severe neglect, maltreatment, and so on. Even when adequate primary caregiver is duly available, child does not turn to for comfort and support and nurture, and to be diagnosed within first 5 years of life. I think that's a very important point, and the same has been there in DSM also, and cannot be diagnosed before the age of 1 year or developmental age of 9 months. Exclusion Asperger syndrome and disinhibited attachment disorder of child. So this is disinhibited social engagement disorder, that is a grossly abnormal social behavior in the context of history of grossly inadequate child care. Again, child approaches adult indiscriminately, lacks reticence to approach, and will go away with unfamiliar adults and so on. Again, the same like reactive attachment that within first 5 years and cannot be diagnosed before the age of 1 year, development age of 9 months. And these are the exclusion, that is Asperger disorder syndrome, adjustment disorder, ADHD, reactive attachment disorder. Now, this is a new condition, like earlier in ICD-11, ICD-10, we have the Z category or Z code, which was there, but now we have the Q, which is, like the 6th chapter is for mental disorder. This is the 24th chapter. These are factor influencing the health status or contact with the health services. Now, why I'm mentioning here, because burnout is mentioned here, that 2D85, that's burnout, acute stress reaction, because burnout we are talking a lot nowadays, and acute stress reaction, uncomplicated bereavement. So these are the new Q code which is there in place of new Z category. Z has been replaced by, as you know, that Y is for others and Z is for the unspecified. That is why the term is replaced with the Q code now. Now, acute stress reaction, again, which is QE84, acute stress reaction, and these are some of the other conditions which are there. That is other specified problem associated with harmful or traumatic event and so on, which are related to stress and so on. Acute stress reaction, it's described as a transient emotional, somatic, cognitive, or behavioral symptom as a result of exposure to an event or extremely threatening or horrifying, that is natural human-made disaster. And a response to a stressor is considered to be normal given the severity of stress. We all know about this, but as we say, that the normal reaction to abnormal situation usually begins to subside within few days after the event or following removal from the threatening situation. Inclusions are acute crisis reaction, acute reaction to stress, and these are the exclusion, that is post-traumatic stress disorder, which are part of the main disorder. So acute stress reaction is not a disorder. Again, I am repeating here. Versus DSM, again, in contrast to status, both ICD-10 and DSM-5, acute section is no longer considered a mental disorder in ICD-11 and is located instead in the chapter on factors influencing on health status or contact with the health services. Burnout, again, resulting from chronic workplace stress that has not been successfully managed, and there are 3 dimensions, that is feeling of energy depletion or exhaustion. That's what the definition of burnout is. Increased mental distance from one job or feeling of negativism, a sense of ineffectiveness or lack of accomplishment. Specific in the occupational context and should not be applied to describe experience in other areas of life. That's a burnout. Now, what are the implications? Just to briefly talk about proposed ICD-11 PTSD criteria have identified fewer number of cases compared to ICD-10, DSM-4, and DSM-5. But again, it's too early to say that. We all will know when the more data evidence is available to us. However, ICD-11 identify more cases of PTSD in one child sample. So at one evidence, there are fewer, but there are more cases has been identified because some of the criteria has been simplified in a child sample. Given that complex PTSD is a newly defined condition, so there has been no clinical trial, so we do not know about therapies and so on. So time will tell us in future that for this newer condition. Adversity is associated with adjustment disorder. We all know adjustment disorder. There can be a suicide. And this classification to non-disorder diagnosis may project as a normalcy and may defer a treatment. So sometimes we need to look at this condition more closely, adjustment disorder, which may look like a subsyndromal and so on. But again, this is an important condition, and there are evidence that one may it may lead to a suicide attempt and so on. So one has to look at more closely. So take-home message again is to ICD-11 to improve communication more so with stress-related condition, ease of use and treatment planning. Stress-related disorders are clubbed together. Basically, they are all related to stress. and uniformity with DSM as compared to ICD-10. Proposed criteria 11, ICD-11 criteria, that is separating PTSD and complex PTSD. That's one of the important thing has been there. Prolonged grief disorder, a new diagnosis, and acute stress reaction and burnout are now classified as a factor influencing health or status or quantitative health survey, not as a mental disorder in the core category. With this, I will end here. I think I've taken slightly more time, but yeah, I'll be happy to, if there are more questions. And some of these points we can have in our afternoon session, some of the discussion on the clinical big data and so
on. Thank you very much, sir, for your kind words and knowledge you have shared with us. And I'm Dr. Lalit Kumar Singh. I will try to take up some very important questions which have been raised by different people and participants. Sir, sir, there is a question by Yaman Devi, how to differentiate affect regulation in complex PTSD from PTSD with depression or with bipolar borderline personality.
Can you repeat how?
Yes, sir. Yes, I'm repeating question, sir.
Okay.
How to differentiate affect dysregulation in complex PTSD from PTSD with depression or with borderline personality?
Yeah, I think that's a very important point. And affect dysregulation is not a feature of of PTSD, but it is a feature of complex PTSD. What is being thought that some of those emotional dysregulation and some of those features, which again are seen associated with PTSD, and so that is why the label is given as a complex PTSD. But how to differentiate basically it's a differentiation. If it is present, then obviously it comes as a part of a complex PTSD. So that's how it is. And it has been the core group of this particular disorder have mentioned that it is difficult to differentiate with the borderline personality disorder also. But the key thing here would be that we have to look at not only affect dysregulation, but we have to look at the other features also to really differentiate between these disorders. So only one symptom will not determine whether it's a complex PTSD or not. And we all know there are differentiating features for borderline personality disorder. Like say, for example, for complex PTSD, we need to have a horrifying or threatening event as a trigger, which may not be the feature of borderline personality disorder and so on. So of course, it is not a one condition, one feature, but associated other condition which will determine the condition. Of course, there are people who have done the prefrontal cortex and they had looked into more subtle differences. But by and large, we have to see totality. But also, let me tell you that this is all preliminary because complex PTSD is just a new condition. Now, more evidence will come in the future. So it will be too early to talk about it.
Sir, there is one more question which has been asked by Kumari Reena. She's asking that is there any difference between problems in affect regulation in complex PTSD versus affect I regulation in EUPD?
Yeah, I think it is again as what we discussed affect dysregulation part. What we discussed, it will be difficult to differentiate the two. If it is part of complex PTSD, again there would be other features also. But affect dysregulation is one feature. Now if we have to make a diagnosis of complex PTSD, then we have to go look at the other features also. But it can affect dysregulation is a presentation. Now it can be there for other conditions also. So we can't say that how they will be different in that. The difference would be the associated other conditions and the problems.
Thank you for your questions, sir. We are already run out of time. So Akaneza sir asking us to close the session early, so that they can, the other question, there are two more questions, most probably that might be taken in the evening session, where they will have a breakout session. During that time, they can ask the questions with you. Thank you, sir.
Thank you, sir.
Thank you.